There are a number of minimally invasive and non-invasive monitors that are currently used to assess cardiac output. Before using these monitors, it is important to ensure that the information provided accurately reflects the patient's actual cardiac output. This video provides an overview of the validity of the Cheetah NICOM non-invasive cardiac output monitor. Any monitor used to measure cardiac output has inherent inaccuracies. The gold standard laboratory model is an aortic probe. In clinical practice, the pulmonary artery catheter is viewed as the gold standard. Pulmonary artery catheters providing continuous cardiac output measurements are preferred over those that intermittently measure cardiac output by thermal dilution. As all monitors have inherent inaccuracies, the Bland-Altman method of analysis is recommended whenever comparing two technologies that are measuring a given parameter, such as the cardiac output. Ideally, the monitor should have a mean percentage error of less than 30% to be viewed as providing valid data. To put this in perspective, the FlowTrack pulse contour cardiac output monitor produced by Edwards, and which has been widely adapted clinically, has repeatedly been shown to have an error between 40 to 45%. The gold standard pulmonary artery catheter thermal dilution method has an inherent error of up to 10% when triplicate measurements are averaged. The esophageal Doppler monitor has been validated and studied extensively. It has been shown to be a useful tool to optimize flow-related hemodynamic variables and reduce morbidity and mortality. Based on the best available evidence and expert advice, the UK National Institute of Clinical Excellence found that it offered proven advantages for both patients and the National Health Service. The UK NICE guidelines in 2011 advised clinicians that the monitor should be considered for use in patients undergoing major or high-risk surgery or for other surgical patients who may require invasive cardiovascular monitoring. The Institute calculated a cost savings for the national healthcare system of over £800,000 a year based on reductions in surgical complications and length of stay that could be realized with this technology. The Cheetah NICOM monitor has been validated in the laboratory model using an aortic probe. It has also been validated against the Fick method of cardiac output measurement and against the continuous cardiac output pulmonary artery catheter. When cardiac output was measured in an open chest dog preparation with an aortic probe, the average differences in cardiac output measured from the aortic probe and the NICOM monitor was less than 5%. Rapid changes in cardiac output were accurately tracked by the NICOM monitor. The NICOM measurements of cardiac output were compared to those measured from a continuous cardiac output pulmonary artery catheter with over 65,000 paired measurements in postoperative cardiac patients. Again, the NICOM monitor was found to accurately track the pulmonary artery catheter measurements with an acceptable calculated error of 9%. Professor T.J. Gann recently demonstrated that the NICOM is an acceptable alternate monitor to an esophageal Doppler for goal-directed fluid therapy. Compared to the esophageal Doppler, the NICOM monitor was less affected by intraoperative cautery and was able to capture significantly more data during the surgical procedures. It is less invasive and easier to use than an esophageal Doppler. Unlike the esophageal Doppler, the NICOM monitoring system can be used postoperatively in the spontaneously breathing patient. The NICOM system also provides a measurement of the stroke volume index that, unlike stroke volume variability, does not require controlled ventilation to predict whether or not a patient is fluid responsive. So in summary, the NICOM monitor has been validated for monitoring stroke volume and cardiac output against the gold standard continuous cardiac output pulmonary artery catheter. It has been found to be as good or better than an esophageal Doppler monitor for measuring stroke volume for goal-directed therapy. In the following video, Professor Paul Hurt discusses his experience with the NICOM during his lecture at the 2012 Society for Critical Care Medicine Symposium.
Now, as I mentioned, we've pushed this. I have a hard time believing a lot of these things. So before I ever used it in a patient, I used it on myself, my wife, my kids, the dog, my nieces and nephews, and a whole range of laboratory animals. And one of the animal studies that we first did actually involved a study we were doing in dogs that had nothing to do with a NICOM. As part of the thing that goes on in my laboratory is we do a lot of subcontract work where we describe cardiovascular side effects of novel molecules. And in doing so, we use a lot of open chest and other instrumentation. We also do a surgical preparation in this, and once I got initial box, which if you haven't seen it is a simple little light device, it measures non-invasive blood pressure, it gives you an EKG trace, and as a side effect, it also gives you the flow. We started using it in some of these drug development protocols simply as a intraoperative monitoring device. And this is an example shown from a 9.1 male beagle, gave a beautiful trace, a cardiac output of 1.1 liters a minute, a non-invasive blood pressure. We let it run in the background, and as I mentioned, these are open chest preparations with a flow probe on the aorta, which has been our laboratory standard for years. And finally, when I got around to actually looking at some of the data that we acquired in the background with the NICOM, the aortic flow probe is at a 5-second average. The NICOM comes out at a 30-second sample. It looked like this. And I kind of went, this is a little interesting. There may be something here. Eventually, we went on and we looked at a variety of these where we were giving these incremental dosing of these drugs and looking at side effects. This would be heart rate with the derived from the aortic flow shown in black, the NICOM shown in red, and then this is the change in stroke volume that occurred with incremental larger doses of these study compounds. And they actually seem to line up quite well. So eventually we went back and we compiled all these data from a variety of these drug development studies. And this is a paper that we published just this last year, which described the use as a non-invasive alternative to open chest monitoring in these drug development protocols. And it found that it was actually quite precise and it was quite accurate, and we could track changes in blood flow that we traditionally had used with open chest instrumentation. Now, to my surprise, this actually generated a lot of interest. One, it showed a real precision of the device in an invasive model comparison, but it's also generated a lot of interest in the industry and in the animal use side, and I've gotten a lot of emails about this, because what we do now is we do these studies, we don't open the chest, we recover these animals, and we actually give them away. And so it's been an interesting progression of how we do our practice. But, okay, so I've kind of convinced myself that maybe it works in a laboratory setting, but what about in the clinical environment where we all work? And I'd like to progress on in using these things postoperatively. And the truth is that when you're talking about electrodes stuck in the chest, people move. And they wiggle and they squirm and the stuff falls off and you go to check your data and it's gone. So one of the first things I did with this was I actually put it on myself, knowing that at night I wiggle and I squirm. I put the electrodes on, I hit the button, and I went to sleep. And here's what I find. Well, it's kind of interesting. I woke up the next morning thinking there would be gaps in the data, and there weren't, and there's this nice cardiac index. But I saw this area here where my cardiac index was less than 1.5. And my first response is, well, obviously this device doesn't work. Then I look back in the literature, and there's this paper published in 1967 that was actually looking at cardiovascular responses during sleep. And they found in non-REM sleep, and they put PA catheters and arterial catheters into patients, and found that in non-REM sleep, indeed, there's a profound cardiovascular depression that occurs. And I got to thinking, well, maybe it isn't wrong. I like to drink red wine once in a while, and I was delighted when I saw this paper a couple years ago showing that not 1 but 2 drinks of red wine actually raises your cardiac output and maybe is good for you. Now, I also know that if I drink much red wine, I wake up at night, my heart's pounding, probably from the tyramine absorption, and I don't know if that happens to any of you. But in the sake of science, I thought, okay, and I drank a bottle of red wine, and I put the electrodes on, and I hit the button, and I went to sleep. And here's what I found that was distinctly different. And in the nature of full disclosure, after the red wine, I felt awful, and after this one, I felt great. But sure enough, consistent with what had been published, my baseline cardiac output was substantially higher. And here's this period of time when the cardiac output went way up. And when I tracked it through, exactly what I would find is there's a point where I wake up and my heart's pounding, and the black shows stroke volume, and there was an initial rise in cardiac index that occurred that was entirely stroke volume mediated, and the secondary rise was entirely related to my heart rate. Okay. Well, I know that the leads aren't going to fall off at night and that red wine gives me a hangover, but in the perioperative environment which we work, how practical is this? How really practical is this? And I get to thinking about our patients, many of whom I take care of, that have major intrathoracic non-cardiac surgery, let's say an esophageal cancer patient that's going to have an esophagectomy. And if we take the description of how the leads are placed, and we say, well, actually, the patient may have a subclavian line. They're going to get an incision in their abdomen and their chest and in the neck, and they're going to have a chest tube on one side and a chest tube on the other. They're going to have bandages put over all these things, and a lot of the patients have an AICD pacer, and then they're going to go to the unit and they're going to have leads put all over them. How practical is it with this array of electrodes? Okay, well, maybe the device seems to work, but I don't know how in this perioperative environment it's really going to behave for us. So after approval of the local IRB, my wife, and recruiting a subject who's my son and saying he would be anonymous, we put him down and we put the leads on. He's actually sitting over here today, but We put the leads on in a variety of different arrays, and we looked at what happened. At close, spread out, on the back, spread out, and then flipping them over. And some interesting things came out. First, I don't know if you can see it, but in this array in the back, it's reading that his cardiac output is 4.8 and an enviably low heart rate of 52. We flipped him over, the lead's in the exact same place, but now he's gone from prone to supine, and the cardiac output is 5.5. And my first response is, aha, there's something having to do with the position here, that the signal doesn't work and the device doesn't work anymore. Of course, then I found this paper showing that turning healthy patients prone produces a clinically significant in cardiac output. So what we did is we detected the change that had been described previously simply by turning him over.